Hello everyone and welcome to another presentation of HLS pharmacology. In this presentation we will be discussing the use of antiplatelet agents. Note that the reference for this presentation in your textbook is chapter 21, which also discusses anticoagulants, which is the topic for the next presentation. Let's first start talking about thrombosis. Thrombosis is defined as the formation of an unwanted clot within a blood vessel. The formation of this unwanted clot can result in a variety of pathologies, such as myocardial infarction, which is caused by abnormal thrombosis in the coronary vessels, deep venous thrombosis, which occurs due to the formation of blood clots in the large veins of the lower limbs, pulmonary embolism, which results from the occlusion of pulmonary arteries by emboli, and cerebrovascular accident or stroke. All of these disorders are serious and associated with high rates of morbidity and mortality. And these disorders are treated with drugs such as anticoagulants and fibrinolytics. It is very important to remind you with the difference between the two terms, thrombus and embolus, which I'm pretty sure you have heard so many times before. In this graph, you can see how blood flows normally back into the heart through major veins in the body. When a clot forms and that clot is localized and adherent to the vessel wall, we call that a thrombus. Whereas when the intravascular clot that then floats in the blood is termed an embolus. Okay, a thrombus is localized to the vessel wall and forms locally at a certain area in either arteries or veins, while a dislodged or a detached thrombus, you can see here that this embolus has detached from originally formed thrombus. Okay, we call this an embolus. Both thrombi and emboli are very dangerous. For example, if thrombosis happens in coronary vessels, for example, the increase in the size of the thrombus can eventually occlude the majority of blood flow from that vessel. And as you remember, coronary vessels supply oxygen and nutrients to the cardiac muscle. So a thrombus will prevent further supply of oxygen and nutrients to the cardiac muscles, leading to a myocardial infarction. At the same time, when an embolus is dislodged from an already formed thrombus, it can travel to many places in the body, like, for example, the pulmonary circulation, leading to the occlusion of blood flow to the lungs. And that what happens during pulmonary embolism. So both these examples, myocardial infarction and pulmonary embolism, are dangerous conditions that require urgent treatment. Now, thrombosis can be either divided into either arterial thrombosis or venous thrombosis, depending on the site where thrombus occurs. Arterial thrombosis most often occurs in medium-sized vessels, which become highly thrombogenic by the accumulation of atherosclerotic plaques. Okay, so atherosclerosis plays a major role in arterial thrombosis. These arterial thrombi are usually consistent of a platelet-rich clot. So the clot that forms in arteries or that make up arterial thrombi has lots of platelets in them. On the other hand, venous thrombosis is triggered by either blood stasis or the inappropriate activation of the coagulation pathway. Now, in comparison to the arterial thrombus that is platelet-rich, venous thrombosis typically involves a clot that is rich in fibrin, with fewer platelets than that observed with arterial clots. This is important because this will direct the pharmacological treatment of both conditions. Okay, in order to understand what is the physiological role of thrombi, we need to revisit how the body deals with physical injuries to blood vessels. So when a blood vessel is subjected to a physical trauma, and that can be either a cut or a puncture or any type of other physical traumas that will result in the damage of the blood vessel wall and bleeding or extravasation of blood components, um, that trauma initiates a series of complex interactions between three main players in the blood. Okay, these players are the endothelial cells that line the vessel wall, platelets that are normally circulating in the blood, and the coagulation pathway consistent of many different coagulation factors. So these three components play together in order to achieve one goal, is that we need to stop the bleeding that is caused by the physical trauma. This is the main purpose of these three components. So what happens after a physical trauma, such as a cut or a puncture to a blood vessel, whether it was an artery or a vein? The first response that happens normally is vasospasm, or constriction of the injured blood vessels. This happens because it will reduce blood flow through the damaged blood vessel and definitely will reduce the amount or the volume of blood that is lost through the damaged area of the vessel, meaning that it will reduce bleeding. This is followed by the formation of a platelet fibrin plug. So, for example, if the damage is in this portion of the blood vessel, you will notice that after the vessel constricts or undergoes vasospasm, this puncture that happened in the blood vessel wall will be occluded by a platelet fibrin plug. At the same time, a thrombus is formed. So normally, this response is very important for the cessation of bleeding following physical trauma to blood vessels, meaning that thrombus formation is part of a physiological response to vascular injury. The problem is that when thrombus is created either excessively or in an unwanted place, and thrombus formation, even if it was abnormal, will definitely involve the same steps as normal clot formation, except that the triggering stimulus is usually pathological. Okay, so it's usually an abnormal condition. It is normal to induce thrombus formation in response to vascular injury. However, it's not normal for thrombi to form at the sites of accumulation of atherosclerotic plaques, for example. Okay, so thrombi usually happen or are stimulated by abnormal or pathological stimuli rather than just the simple external physical. So in this lecture, we will focus on drug treatments that interfere with the formation of the platelet fibrin plug, which is the second step in the response to vascular injury. So in order to understand that, let's take a look into the mechanism of the formation of the platelet-rich plug in more details. As you know, platelets act as guards of the vasculature, and they constantly monitor the integrity of the vascular endothelium. They make sure that it's intact and not damaged. In the normal state, where there is no injury, platelets circulate in the blood freely and that is due to the balance of the chemical signals that tell the platelets that everything is okay and that the vessel wall is not damaged, the endothelium is intact, there is no damage, and that's why the platelets have to remain in an inactive state. We call it the resting state. We call them resting platelets. This is mainly so prostacyclin that is synthesized and released by the intact endothelium then binds to its receptors that are located on the outer surface of the resting platelet membrane. Binding of prostacyclin to its receptor results in the activation or the increased synthesis of this intracellular second messenger cyclic AMP that is usually converted from ATP molecules by the action of the enzyme phosphodiesterase. The rise or the increase in the intracellular levels of cyclic AMP results in the inhibition or the decrease of intracellular calcium levels, right? So the majority of calcium becomes sequestered in the endoplasmic reticulum or in the mitochondria, and its levels in the cytosol are decreased significantly. Decreased intracellular calcium levels prevents the platelet from being activated and prevents the subsequent release of many mediators that result in platelet aggregation. Now, in case of vessel damage, when the vessel is damaged, or if the endothelium is damaged by physical trauma like a cut wound, the endothelial cells will synthesize less prostacyclin, which means that there will be less prostacyclin available to bind to the prostacyclin receptor on the resting platelet. This will result in the opposite of what happens during the resting state, in that there will be less cyclic AMP and more calcium inside the cell. Elevated calcium levels inside the resting platelet will allow for platelets to aggregate at the site of injury, and that is the first step that initiates platelet activation and aggregation. While prostacyclin is very important in keeping the platelets in the resting state, there are other mediators that antagonize the function of prostacyclin and they drive the platelets into activation. These mediators include thrombin, different types of thromboxane, and the exposed collagen. Platelets have surface receptors for all of these mediators. In the healthy, intact blood vessels, when there is no injury or physical trauma, circulating levels of thrombin and thromboxane are usually low. So in the normal conditions, thrombin and thromboxane are low. And in that case, in the blood vessel, if it's intact and there is no physical trauma, the endothelium covers collagen that is present in the extracellular matrix. Okay, so there is no exposed collagen. In the case of injury, the levels of these mediators are increased, which results in platelet activation. And then because of the injury, part of the endothelium will be lost and damaged, meaning that the platelets will be exposed to collagen. Binding of platelets to collagen will also result in platelet aggregation. So we've just discussed the chemical balance between prostacyclin and so platelets bind to the exposed collagen of the connective tissue underlying the endothelium at the site of injury through several receptors that recognize collagen and bind to it. And this leads to two main events in the activation of platelets. The first is that platelets start undergoing morphological changes from how they used to look in the resting platelet state into how they look in the activated state. And these images were taken by an electron microscope. The second most important event is that binding or adhering of the platelets to collagen results in the release of the constituents of multiple platelet granules into the exterior. These granules are, of course, released as we talked about due to the sudden rise of calcium levels inside the cell. These granules contain many platelet activating mediators, including ADP, which is a very important platelet activating mediator, thromboxane A2, serotonin, platelet activation factor, and thrombin. The release of these mediators results in definitely the further activation of the platelet that released it in an autocrine fashion, as well as the activation of other resting platelets that are circulating in the blood nearby the site of injury. So, in other words, the receptors on the surface of the platelets function as sensors. And once they are bound to exposed collagen, meaning that there is a physical injury, they are immediately activated and they start immediately triggering the release of many other platelet activating factors that will recruit more platelets and result in platelet activation. So again, to remind you that the release of all of those platelet aggregating factors such as thromboxane and ADP is stimulated by two major changes that happen inside the platelet, which are the sudden decrease in cyclic AMP levels and the rapid rise of intracellular calcium levels. Both of these events result in the release of the constituents of platelet granules containing all these mediators, which will further enhance platelet adherence to the site of injury and the aggregation or activation of other resting platelets in the nearby. So let's quickly revise how a platelet is activated from the resting plate. It starts with the adherence of the platelet into the exposed collagen, which activates the release of multiple platelet activating mediators that are found in the platelet granules into the outside. These mediators include thrombin and ADP, which can activate the platelet itself further and can act on adjacent resting platelets to activate them. The release of these mediators usually happens in response to increased intracellular calcium levels. At the same time, increased intracellular calcium levels initiate the synthesis of prostaglandins, in particular thromboxane A2. So this also happens in the activated platelets. Thromboxane A2 is itself induces further platelet activation and aggregation. Now, the next step after the platelet is activated, these platelets need to start aggregating, forming the platelet plug. And by aggregation, we mean that the platelets need to start sticking next to each other. And that forms a plug or a seal, which prevents further bleeding from the damaged site of the endothelium. And this usually happens by the activation of a specialized receptor found on the external surface of the platelet called glycoprotein 2A, 2B3A. So this receptor is always expressed on the surface of the platelet, but in the resting state, it's inactive. When the platelet is activated, and that's usually due to increased levels of intracellular calcium, this receptor becomes activated, and this receptor binds the protein fibrinogen. Interestingly, an adjacent activated platelet that also has an active glycoprotein 2B3A receptors on their surfaces can both bind the same fibrinogen molecule. And this creates a cross-link between two adjacent platelets, resulting in their aggregation. So fibrinogen is a soluble plasma glycoprotein that binds two adjacent glycoprotein receptors in two separate platelets, resulting in platelet cross-linking, as you can see here. So each two adjacent platelets will use these receptors to form a crosslink. And as these crosslinks build up, platelets start aggregating, forming the platelet plug. Okay, so this is how platelet aggregation happens, and platelet aggregation definitely requires the activation of the glycoprotein 2B3A receptors. So to summarize, we have mentioned before that the first response to vascular injury is vasospasm of the injured vessel, which is followed by platelet activation and aggregation that lead to the formation of the platelet plug. The next step would be thrombus formation. So how does that happen? So as the platelets are being activated, local stimulation of the coagulation cascade by tissue factors released from the injured site and by mediators on the surface of platelets will result in the formation and or the activation of a coagulation factor called thrombin. Thrombin is formed from prothrombin. So this is the first event that happens or that is activated during activation of the coagulation cascade that leads to thrombus formation. Remember that thrombin is also referred to as coagulation factor 2 activated or 2A. Thrombin is a serine protease that has the ability to cleave fibrinogen into fibrin, which is then incorporated into the plug. So thrombin cleaves the soluble glycoprotein fibrinogen into fibrin threads, which then starts to be deposited at the site of the platelet plug. Fibrin's role is to stabilize the adhering platelets and form the platelet fibrin plug that should seal the damaged portion of the vessel wall. Remember here that fibrinogen now plays two roles. First, it acts as the sticky agent that joins two glycoprotein 2A, 3B receptors together to form the platelet plug, or it plays an important role in platelet aggregation. And the second function of fibrinogen is that it is cleaved by thrombin to form fibrin threads that form the fibrin-rich clot. So remember, in the normal conditions, in that if you are exposed to a trauma or a cut wound that results in vascular injury and bleeding, it is important that you will be able to successfully form a platelet plug in addition to thrombus formation at the site of injury to prevent further bleeding. However, you do not want the newly formed fibrin clot to continue growing indefinitely. Otherwise, this will result in a very large clot that will occlude the blood vessel, and that will definitely interrupt blood flow to that site that has been exposed to trauma. We don't need for that to happen in the normal conditions. So for that, we must regulate how fibrin clots are formed and how large can they get. And that is why another antagonizing pathway called the fibrinolytic pathway is usually activated as the clot is being formed. This pathway is activated by the release of a factor called tissue plasminogen activator that has the ability to convert plasminogen into plasmin. Plasmin has the ability to break down the fibrin fibers that are deposited at the clot site, and that limits the growth of the clot and dissolves the fibrin network as the wound heals. So thrombin results in the formation of the clot, while plasminogen breaks down the clot, and that keeps you in a state of balance so that the clot does not reach a large size that will block blood flow in the blood vessel. Let's just revise these concepts very quickly. The glycoprotein that facilitates platelets aggregation and is cleaved to form the fibrin clot is called. The serine protease that is involved in the formation of the fibrin clot is called. The enzyme that is responsible for dissolving the fibrin clot and preventing it from growing into a very large size that will occlude blood flow in the blood vessel is called. Now think about this. What happens if you pharmacologically interfere with the increase in the intracellular levels of calcium inside the platelet when tissue injury or blood vessel injury happens? What happens if you design a drug that will prevent the increase that happens in intracellular calcium during injury? Think about this question. So all the steps that we have discussed so far describe the events that lead to the formation of a platelet, fibrin plug, and thrombus formation in order to stop bleeding or extravasation from a damaged or traumatized blood vessel. This means that thrombus formation is normal and part of the physiological process that is designed to stop bleeding from a damaged vessel. The problem is that when a thrombus forms in an abnormal place due to an abnormal stimulus that is usually does not involve physical trauma or injury to a blood vessel. Remember too that the formation of an unwanted thrombus usually happens through the same pathways that we have just described. Meaning, if we want to design effective drugs to interfere with platelet activation and aggregation that lead to the formation of an unwanted thrombus, we will have to target the same pathways that are involved in the formation of a platelet plug during vascular injury. This means that multiple targets of that pathway, including cyclooxygenase 1, glycoprotein 2A3B, and ADP release and receptors are all possible targets for designing effective antiplatelet drugs that we can use to interfere with the formation of an unwanted thrombus. So let's start discussing examples on the available antiplatelet drugs. In this table, all the available antiplatelet drugs are listed, in addition to some of their relative adverse effects and drug-drug interactions. Note here that when these drugs are prescribed, we would like to monitor their actions by measuring certain important parameters, including complete blood count, liver function tests, and bleeding time. The main effects of the platelet aggregation inhibitors is that they can decrease the formation of the platelet-rich fibrin clot that occur during the formation of an unwanted thrombus, and they can interfere with the chemical signals that can promote platelet aggregations, resulting in the prevention of thrombus formation. Ask yourself this question: if these drugs interfere with the steps that lead to platelet aggregation, can they dissolve an already formed fibrin clot, or can you use them after the unwanted thrombus has been formed? Think about this, and you can also find the answer to this question in your textbook. The ability of these drugs to interfere with platelet aggregation or the formation of the platelet plug allow us to use them for the treatment of a variety of thrombotic diseases. They can be used, for example, for the prevention and treatment of occlusive or thrombotic cardiovascular diseases. Disorders such as myocardial infarction that results from the formation of an unwanted thrombus in the coronary vessels. We can also use them to maintain the integrity of vascular grafts or stents, in Arabic الشبكية, and to maintain arterial patency after these stents or shabakat are installed to maintain blood flow in a certain blood vessel that is occluded by atherosclerotic plaques. And that's why these drugs are major components of the combination therapy that is used for the treatment of myocardial infarction, cerebrovascular accidents, and deep venous thrombosis. Ask yourself this question: can you then use antiplatelets alone for the immediate management of myocardial infarction, especially that when a myocardial infarction patient has reached the emergency room? That means that the thrombus has already formed and it has already occluded a coronary vessel, interrupting blood supply to the cardiac muscle. The answer to that last question is, of course, not. Drugs that inhibit platelet aggregation are used in combination with other drugs for the treatment of myocardial infarction, and they cannot just be used alone. And one of these drugs that is frequently used as a part of the combination of the treatment of thrombotic events or thrombotic disorders is the drug aspirin. Remember that the stimulation of platelets by thrombin or by exposed collagen or even by ADP results in the activation of platelets and the intracellular signaling pathways triggered by the increase in intracellular calcium. One of these pathways, one of these mechanisms that become activated is the liberation of arachidonic acid from the plasma membrane. Arachidonic acid is a phospholipid that is normally part of the phospholipids that make the plasma membrane of the platelets. And once it's released by the action of the enzyme phospholipase, it has become converted into prostaglandin H2 by the enzyme cyclooxygenase 1. So cyclooxygenase pathway plays an important role in prostaglandin synthesis and the activation of platelets during platelet activation and aggregation. Prostaglandin H2 is then converted to a variety of prostaglandins, but more importantly, it is converted into thromboxane A2, which we've discussed before, plays an important role in platelet activation and aggregation. So how does aspirin interfere with thromboxane A2 synthesis? Aspirin inhibits the enzyme cyclooxygenase 1, which results in the inhibition of prostaglandin and thromboxane A2 synthesis. Note here that aspirin is just the acetylated form of salicylic acid. This is the structure of salicylic acid, and aspirin is different only in that it has an extra acetyl group attached to its aromatic ring. So what happens is that aspirin donates this acetyl group, or it acetylates, in other words, it acetylates a serine residue located in the active site of the enzyme cyclooxygenase 1, resulting in the irreversible inactivation of the enzyme. So aspirin irreversibly inhibits the enzyme cyclooxygenase 1 by acetylating a serine residue in its active site. This results in the inhibition of the enzyme function that is required for prostaglandin H2 synthesis and then consequently inhibits further thromboxane A2 synthesis. And this shifts the balance of chemical mediators in the favor of the anti-aggregating effects of prostacyclin or prostaglandin I2, thereby preventing platelet aggregation. See, if the platelet function is under balance between prostacyclin, which inhibits platelet aggregation, and thromboxane, which stimulates platelet aggregation. If aspirin blocks thromboxane, then the platelets will be under the influence of the anti-aggregation chemicals such as prostacyclin. The inhibitory effects of aspirin are very rapid, and aspirin-mediated suppression of thromboxane A2 synthesis is prolonged, and the resulting inhibition of platelet aggregation will last for the life of the platelet, which is usually 7 to 10 days. Remember, this results because aspirin irreversibly inhibits the enzyme. So whatever enzymes that have been inhibited by aspirin, they can no longer come back to activity. And that's why you will have to wait until a new platelet has been formed in the bone marrow. So if a patient has been chronically taking aspirin in order to restore normal platelet function, you will have to wait for 7 to 10 days after stopping aspirin treatment. This is why most patients who take aspirin um, as antiplatelet drug will have to stop aspirin for 7 to 10 days before undergoing surgeries, major surgeries, because otherwise they will be at risk for bleeding. This leads us to the therapeutic uses of aspirin. Because of this strong antiplatelet effects of aspirin, it can be used to reduce the incidence of myocardial infarction in those patients who are at risk or have suffered from recurrent coronary blood vessel accidents or recurrent myocardial infarctions. Remember here that aspirin is not used as a single drug or alone for the treatment of acute myocardial infarction. It's part of a combinational therapy, and then it can be used as a prophylactic agent against further thrombotic events that can lead to myocardial infarction. It definitely has been shown to reduce the mortality resulting from myocardial infarction, and it can also be used in the prophylactic treatment or the preventive treatment of transient cerebral ischemia that also results from the formation of unwanted thrombi in the cerebral circulation. Note here that aspirin has other uses that are different from its antiplatelet function. All of these uses are used where aspirin is used as an antiplatelet agent. But remember that aspirin can also be used as an analgesic, again, because it inhibits cyclooxygenase 1. It can also be used as an antipyretic to reduce fever. And more importantly, it is used as an anti-inflammatory agent in patients with chronic inflammatory disorders, such as, for example, rheumatoid arthritis. But note here that these effects of aspirin are dose dependent, and the dose that is required for aspirin to exert its antiplatelet function is usually a low dose of 75 milligram per day. That's what you need to be able to reach the antiplatelet effects of aspirin. If you want to achieve more effects such as anti-inflammatory and antipyretic effects of aspirin, you have to increase the dose that is given to a patient every day. The range of the antiplatelet dose, where aspirin is sufficiently exerting an antiplatelet effect, is usually between 50 and 300 milligrams per day. But the ideal dose is 75 milligrams per day to produce complete platelet inactivation. Uh, Aspirin is frequently given orally, and it is rapidly and passively absorbed from the gastrointestinal tract. And as it passes through the portal veins, it undergoes first pass metabolism, and it's hydrolyzed into salicylic acid. Remember that just the conversion of aspirin to salicylic acid means that you just need to lose this acetyl group, which is a very simple reaction. This means that aspirin has a relatively short half-life of 15 to 20 minutes. However, don't forget that the metabolite or the byproduct of aspirin metabolism, salicylic acid, has a longer half-life. And it's very important to keep that in mind because uh, salicylic acid is also active, and its buildup in the body can be associated with toxicity, as we will discuss later. And after that, salicylic acid and its further metabolites are then excreted in the kidney. Note that because of that, aspirin will have several drug-drug interactions based on its mechanism of action and metabolism in the liver. For example, if aspirin was given with a drug ketorolac, the patient will be under increased risk of bleeding, uh, since we said that aspirin and its metabolites are secreted in the kidney. It can also cause nephrotoxicity if given with the antiviral drug Cidofovir. And lastly, if aspirin was combined with probenecid, they can both interfere with uric acid elimination or secretion in the kidney, resulting in increased uric acid levels in the blood. This can be a problem, especially in patients who have gout and taking therapy to reduce uric acid levels in the blood. Despite that aspirin is a widely used drug with a relatively safe profile, aspirin can also be associated with a number of adverse effects. And you can guess that the major adverse effect of aspirin is bleeding, since aspirin interferes with platelet aggregation and the formation of the platelet fibrin plug. Remember that this process is very important to repair damaged vessels or vessels that have been exposed to physical injury. So patients who are taking aspirin for a prolonged period of times have an increased risk of bleeding, especially from the gastrointestinal tract, or an increased risk of cerebral hemorrhage. Bleeding time is often prolonged by aspirin, and that can result in complications or a variety of bleeding problems. Remember here that non-steroidal anti-inflammatory drugs, such as the drug ibuprofen, also exert their effects by binding and inhibiting the enzyme cyclooxygenase 1. The difference is that a drug such as ibuprofen binds and inactivates the enzyme in a reversible fashion. Okay, so what happens if you give aspirin at the same time as ibuprofen? What happens is that ibuprofen will already have occupied the active site of the enzyme COX-1, and that will prevent the aspirin from also binding to the active site. This doesn't mean that you can't combine aspirin and ibuprofen in the same patient, but when you combine aspirin with non-steroidal anti-inflammatory drugs, they have to be given at least 2 hours apart from each other. Remember also that aspirin can be associated with other side effects other than bleeding, including an angioedema or an allergic reaction caused by hypersensitivity, Aspirin and other NSAIDs can also cause bronchospasm, and that's why they should be used with caution or even contraindicated in patients with asthma. They definitely can cause GI disturbances. These drugs are a risk factor for the development of peptic ulcers. And if aspirin was used in children, it will be associated with Rye syndrome, which explains why aspirin is not indicated for use in children younger than 12 years of age. Again, here, remember that we said that aspirin overdose can be problematic. When aspirin is given at a very high concentrations, this will lead to the buildup of its metabolite, salicylic acid, especially that salicylic acid has a longer half-life than aspirin, and that condition is called salicylate poisoning or salicylate toxicity. And this condition is categorized by a variety of clinical symptoms, including tinnitus, which means a buzzing in the ear that the patient starts experiencing. This progresses to defective hearing, agitation, confusion, and even to life-threatening seizures and cerebral edema. The patients usually develop metabolic acidosis resulting from the buildup of salicylic acid. They can have respiratory failure and cardiovascular collapse. So it's a very life-threatening condition. Unfortunately, there is no specific antidote for salicylic poisoning, and you have to manage all these problems separately. For example, patients will require renal dialysis, correction of metabolic acidosis, and probably assisted ventilation if they develop respiratory failure. Let's move now to another class of drugs that interfere with platelet activation and aggregation. This class is called P2Y12 receptor antagonists. Several drugs are classified under this class, and these include ticlopidine, clopidogrel, prasugrel, ticagrelor, cangrelor, and elinogrel. Remember that ADP is one of the important mediators in the activation of platelets, right? ADP along with thromboxane, A2, thrombin, serotonin, and other mediators all result in the activation of platelets during the formation of the platelet plug. So P2Y12 receptor antagonists exert their effects by inhibiting the binding of ATP to the P2Y12 receptor located at the surface of platelets. So P2Y12 is the receptor that binds ADP on the platelet surface. These drugs, such as ticlopidine, clopidogrel, etc., block or interfere with ADP binding to the platelets. And that inhibits the ability of ADP to activate platelets and result in the increase in intracellular calcium, which, as you might remember, results in the activation of the glycoprotein 2B3A receptors. If the platelet fails to activate these receptors, then they will not be able to bind fibrinogen and they will fail into forming the platelet plug. There are, of course, differences amongst the drugs in this class. For example, ticagrelor and cangrelor bind to the P2Y12 ADP receptor in a reversible manner. However, the other agents inhibit the receptor irreversibly. Also, the maximum inhibition of platelet aggregation is achieved in response to these drugs in different periods of times. For example, cangrelor, which is the only drug in this category that is given intravenously, can achieve platelet aggregation inhibition within 2 minutes after intravenous administration, meaning that is the fastest drug to achieve platelet inhibition in this category. On the other hand, the frequently used drug clopidogrel has a longer duration of action, and it can uh, keep platelets inhibited for 3 to 5 days. This is important because when treatment with these agents is stopped, the platelet system that will require this amount of time to be able to recover. So after you stop clopidogrel, usually you will restore normal platelet function within 3 to 5 days. Let us start talking about how these drugs are used in the clinic. Clopidogrel seems to be highly used in this category, and we'll start by discussing the uses of clopidogrel, a very important drug. Clopidogrel is approved for the prevention of atherosclerotic events in patients with recent or acute myocardial infarction, coronary syndromes, stroke, or cerebrovascular accidents caused by thrombotic events in the cerebral circulation, or even peripheral arterial disease resulting from the abnormal formation of thrombi in peripheral arteries. It is also indicated for the use in the prophylaxis of thrombotic events in acute coronary syndrome, whether it was unstable angina or non-ST elevation. And it is used to prevent thrombotic events associated with percutaneous coronary intervention, PCI. Percutaneous coronary intervention means in Arabic قسطرة. So clopidogrel is used to reduce the risk of thrombosis that accompanies PCI أو عمليات القسطرة. On the other hand, ticlodipine is similar in structure to clopidogrel and is indicated also for the prevention or the prophylaxis against transient ischemic attacks or strokes, cerebrovascular accidents resulting from thrombotic events in the cerebral uh, uh, circulation. Stroke and TIA are two different things, but commonly they refer to them as jalta dimaghiya. Of course, jalta dimaghiya refers to stroke or cerebrovascular accidents. TIA is a less severe form of the stroke. That's why ticlopidine is useful in preventing these events in patients who are at risk. However, we usually reserve ticlopidine as a last resort drug, last line, because it is associated with lots of adverse effects. So we only use it when the other therapies have failed. Prasugrel is approved to decrease thrombotic cardiovascular events, similar to the other two drugs that we've discussed. For example, you can use it to prevent acute coronary syndrome, such as unstable angina, ST and non-ST elevation, myocardial infarction, or even myocardial infarction following trying to open the occluded coronary vessels using PCI or using قسطرة ويتنحط شبكية. However, remember that prasugrel is not indicated for the prevention or treatment of stroke or cerebrovascular accidents because it's associated with the increased risk of cerebral bleeding. So you can't use it for that purpose. Ticagrelor, similarly, is used for the prevention of thrombotic events associated with acute coronary syndrome, but also not for the treatment or the prevention of stroke. Lastly, Cangrelor, remember this is the only drug in this category that is given intravenously, and it has a very fast or rapid effect in inhibiting platelet function, and is usually only used in adjunct to percutaneous coronary intervention, أو القسطرة. So it's given at the same time as they are performing PCI. These agents, of course, have slightly different pharmacokinetics, All agents are given orally except cangrelor. Definitely they require oral loading doses. They drugs that are given orally, and they are heavily protein bound. They undergo hepatic metabolism by the CYP450 enzyme, and that they are eliminated mainly in the kidney. And they have a wide range of drug-drug interactions. Of those drug-drug interactions, the interactions with clopidogrel are very important because clopidogrel is a prodrug. Okay, so this has to be has to undergo metabolic activation in the liver into the active form of the drug to be able to be to inhibit platelets. And clopidogrel is activated or is metabolized into its active metabolite by the CYP2C19 enzyme of the CYP450 hepatic microsomal system. That's why patients who have genetic polymorphisms that lead to reduced activity of CYP2C19 enzyme will activate clopidogrel less. This means that clopidogrel is less active in poor metabolizers. On the other hand, clopidogrel will have a reduced effect if it was combined with another drug that is known to inhibit the activity of CYP2C19, such as the PPI omeprazole. So omeprazole is a known inhibitor of the enzyme CYP2C19, which means if it was given at the same time with clopidogrel, it interfere into with its metabolism into its active metabolites. P2Y12 receptor antagonists have a wide range of adverse effects as well. However, the major adverse effect of this class is, of course, bleeding because they interfere with the ability of platelets to form a plug that will prevent further bleeding from a damaged blood vessel. In addition to bleeding, which by the way doesn't have an antidote, ticlopidine, remember that we said ticlopidine is associated with many adverse effects, and that's why we use it as a last line therapy. Ticlopidine can result in granulocytosis or significant reduction in the number of white blood cells in blood. It can also be associated with a condition called thrombocytic purpura, and also can result in aplastic anemia or failure of bone marrow to synthesize many blood components. So it has very serious adverse effects. On the other hand, we mentioned that prasugrel and ticagrelor are contraindicated in the treatment of patients with stroke or transient ischemic attacks. They are only indicated to reduce the risk of events associated with acute coronary syndrome. And that's why these two drugs have gained black box warning for their high risk of bleeding, and that they are contraindicated in the use of patients with previous history of a stroke or transient ischemic attack. This is very important to keep in mind. Let's now move on to the last category of drugs that can also have an antiplatelet effect. And now we'll talk about the glycoprotein 2B3A inhibitors. There are three drugs that fall into this category: abciximab, which is a monoclonal antibody, and eptifibatide, which is a cyclic peptide, and tirofiban. So remember that we said that the glycoprotein 2B3A receptor plays a key role in stimulating platelet aggregation. Two receptors from two adjacent platelets bind a fibrinogen molecule, and then they form a cross-link between adjacent platelet. Abciximab, which is the most important drug in this category, is a chimeric monoclonal antibody fragment that inhibits the glycoprotein 2B3A receptor complex, right? So it inhibits this complex, and by binding to the glycoprotein glycoprotein 2b3a, abciximab blocks its binding to fibrinogen and to van Willebrand factor, and then consequently prevents platelet aggregation or the formation of the plug. Eptifatide and tirofiban both act similar to abciximab by blocking glycoprotein 2b3a receptors. So, glycoprotein 2b3a inhibitors have several therapeutic uses. They are mainly given as an adjunct to percutaneous coronary intervention or PCI for the prevention of cardiac ischemic complications. بنستخدمهم عادة أثناء القسطرة. Abciximab is approved for unstable angina that does not respond to conventional therapy, so it's an alternative therapy to resistant unstable angina. And this image to the right is from a clinical trial that evaluated the effects of abciximab before and during coronary intervention in patients with unstable angina. And you can see here that in this trial, that high-risk acute coronary syndrome patients receiving abciximab within 18 or 24 hours before percutaneous coronary intervention, these patients have less adverse cardiac events after 3 days after receiving 3 days of receiving abciximab. Primarily because abciximab resulted in a decreased risk for developing another myocardial infarction, and you can just compare what happened to patients who received the placebo and those who received abciximab. So it's a very useful drug. These agents also are giving intravenously only. All of them are given intravenously. They undergo rapid degradation in the plasma, which means they have a shorter duration of action. However, restoration of platelet function requires 24 to 48 hours following stopping the treatment with glycoprotein 2b and 3a. Of course, the major side effects of this drug, like the other previous categories, is that bleeding. They can also result in other side effects such as hypertension, nausea and vomiting, and thrombocytopenia. Just to summarize, there are different classes of drugs that interfere with the platelet aggregation and activation pathway. We've discussed aspirin, which blocks cyclooxygenase enzyme, inhibiting and reducing the production of thromboxane A2, which results in the activation of the platelet. We also have discussed drugs that interfere with the binding of ADP with its receptor P2Y12, such as clopidogrel, and interfering with the binding of ADP to the platelet results in reduced activation marked by reduced calcium levels in the cell, which results in failure in activating glycoprotein 2b and 3a receptors that are responsible for platelet aggregation. And lastly, we've discussed drugs that directly inhibit glycoprotein 2b3a receptors, preventing them from binding to fibrinogen and forming platelet-platelet crosslinks. So let's now discuss another drug that has a different mechanism of action than the drugs that we have discussed so far. This drug is called dipyridamole. Dipyridamole has a unique mechanism of action, is that it results in both coronary vasodilation and the inhibition of phosphodiesterase enzyme. Remember that in resting platelets or in the inactivated platelets, the levels of cyclic AMP are high, and that's what keeps these platelets in an inactive state. These cyclic AMPs, which are synthesized from ATP, of course, can be degraded by an enzyme called phosphodiesterase. So, by inhibiting the enzyme phosphodiesterase that breaks down cyclic AMP, dipyridamole increases the intracellular levels of cyclic AMP inside the platelets, and this keeps the platelet in an inactive state by inhibiting thromboxane A2 synthesis and then platelet adhesion to thrombogenic surfaces. That's why dipyridamole is very useful in the treatment and prevention of stroke or cerebrovascular accidents, usually along with aspirin. But keep in mind that dipyridamole, because it's a coronary vasodilator and can be associated with coronary steal phenomenon, is contraindicated in the use of unstable angina because coronary vasodilation caused by dipyridamole shifts blood flow from the areas of myocardial infarction to other areas of the heart, resulting in more ischemia. So it should not be used in patients with acute coronary syndrome. The last drug in this presentation is cilostazol. Cilostazol is another phosphodiesterase inhibitor that results in elevation of cyclic AMP levels inside the platelet, keeping the platelets inhibited. It is used for the treatment of intermittent claudication that is used due to thrombosis in the peripheral arteries. Cilostazol is contraindicated in patients with heart failure. And with that, we'll reach the end of this presentation. Thank you so much for listening. And if you have any questions, don't hesitate to get in touch with me through Microsoft Teams or sending me emails on my email address. Thank you very much.